Thank you all for joining us for Creative Healing for Youth in Pain, or CHYP's March webinar, Hypermobile Ehlers Danlos Syndrome, Risk for Pain, POTS, and More. My name is Ashley Mateka, and I'm the Executive Director of CHYP. For those of you who are new to CHYP, CHYP is an online nonprofit organization that is dedicated to empowering youth living with chronic pain to heal by altering the brain's pain circuits through exposure to creative healing experiences, educational resources, and peer support. Today, we are thrilled to have Dr. Blake Windsor as our guest. Dr. Windsor is the director of the Pediatric Pain, Headache, and Concussion Program at the Children's Hospital of Prisma Health Upstate. We're also joined by CHYP's founder and president, pediatric pain expert, Dr. Lonnie Zeltzer. Thank you, Dr. Windsor and Dr. Zeltzer, for joining us today. Before I pass it over to Dr. Zeltzer, I would like to go over a few housekeeping items. First, please enter your questions in the chat throughout the webinar. Dr. Zeltzer will incorporate audience questions throughout today's conversation. Second, our webinar is being recorded. A replay of this webinar, along with previous CHYP webinars, are available on CHYP's YouTube channel. Finally, I would like to ask you to consider making a donation of $25 to CHYP if you find the monthly webinars valuable. Donations can be made at mychip.org/donation, and I'll be placing that link in the chat as well. Now we're ready to get started.
Hi, welcome everybody, and thank you, Dr. Windsor from South Carolina, for joining us, and thank you everybody for coming. We have a large group today. Maybe we can start off, and again, this is a Q&A, so feel free to ask questions in the chat box. I thought I would start off with asking sort of a big question for Dr. Windsor. It's two parts. Do all hypermobile kids have EDS? And then more start out with, what is hypermobile EDS? What is EDS? What is hypermobile, what we call hEDS?
Well, first of all, thank you so much for having me here today, and I'm really excited to talk about this topic. This is a really, really complicated topic, so I'm going to do my best to really share with you all the way that I think about evaluating kids with pain and hypermobility. So first of all, when we start talking about hypermobility, we need to realize that there is a range of mobility. Some people are undermobile, some people are overly mobile. And where people draw that line when they start to describe hypermobility, too much mobility, it can get kind of gray. Sometimes it's in the eye of the beholder. We do try to have objective criteria as to what indicates what we might view as a pathological form of hypermobility, which means hypermobility to the point where it might be causing injury or damage to the body. But a lot of these things are not clear-cut answers. And I think that's one reason why people, patients and families, have so much confusion around this topic, is because it's not clear-cut. Now, when we start talking about Ehlers Danlos Syndrome, Ehlers Danlos Syndrome is a connective tissue disorder related to a type of protein in the body that is a fundamental connective tissue of all sorts of parts of the body. The skin, the teeth, the organs, tendons, ligaments, bones. And there are multiple types of EDS, 13 different subtypes that are known. And unfortunately, going back to how vague some of this stuff is that the most common type, the hypermobile type, we have not found a genetic cause for it yet. We haven't found the gene. So in the year 2024, to have what we think is a genetic condition of hypermobile EDS, that's that subtype, where we haven't found a genetic cause, is confusing. It's challenging. And I think that gets back to that idea of people drawing a line in the sand as to what is considered a normal degree of mobility and a pathological hypermobility, and people drawing those lines in different areas. So to answer your question, Dr. Zeltzer, not all kids with a hypermobility have hypermobile EDS. They could also just have hypermobility And that mobility is not always from loose connective tissue. We also know that kids who might be hypermobile might also have this lower muscle tone.
Mhm.
And sometimes those lower muscle tones could be related to other disorders. For instance, autism, spectrum disorder. I know that's one that you and I look for a lot, Dr. Zeltzer, is that other reasons why someone might be a little floppier, a little, it's not always from the ligaments being loose, but their resting muscle tone, which do hold joints together, could be lower, could contribute to that. So it's a really, really complicated issue to determine if something is a hypermobility, we think a pathological hypermobility, which means a hypermobility causing a problem, or a hypermobility related to hypermobile Ehlers Danlos syndrome. And there's a lot of research that's still trying to elucidate this.
So can I ask, when should a parent do genetic testing for Ehlers Danlos syndrome?
So I generally don't do it. And whenever I do refer to geneticists, they generally don't do it. When I personally am thinking about doing a genetic evaluation to say, is this going to be one of those forms of EDS that we can find with a gene test? Those are actually the really, really rare ones. So hypermobile EDS, kind of going back to that, where's the line drawn? I've seen studies with a prevalence of 1 in 2,000 people up to 1 in 100, which is a huge range, 1% of the population. But if you look at the second most common form, classical EDS, and then vascular EDS, those have genetic forms. So really, when you're ordering the test, what you're looking for are non-hypermobile forms of EDS.
Right.
And those are all rare, very rare. And they're worth knowing. They're worth knowing. It's one of those things where we don't want, as doctors, we always have to balance this line between not ordering a test 1,000 times that costs thousands of dollars for it to come back positive one time, but never missing that one time when we should have ordered it. And that's a constant tension that we have to find.
So I'm going to read you, there are a bunch of questions related to genetic testing. And let me read these, and then maybe collectively you can talk about it.
Sure.
So please explain why you feel collecting DNA data is not helpful. And then related to that, my son was referred to genetics, would not test, I guess genetics would not test, only said they could not rule it out, but most likely has it based on collection of presenting symptoms and conditions. And then the first person said, due to the complexity of DNA, the more data we collect, the closer we get to determining the DNA or DNA sequence. So that's sort of a group related to DNA testing, to genetic.
To try to wrap those together, I would say, so genetics is actually a lot more complicated than I think than a lot of people realize, because the number of times that I will see a genetic test come back with a variation of unclear significance, where if you look at the people we know have this condition and this gene, but the patient doesn't have any signs or symptoms related to that. So it just gets really, really complicated. Now, kind of going back to some of this blurred lines, my understanding is that in 2017, there was a decision made to tighten up the diagnostic criteria for hypermobile EDS. And so a lot of other features were added into it. And that made it harder meaning that it's a stricter criteria for giving people a diagnosis of hypermobile EDS versus a hypermobile spectrum disorder. And I believe that those efforts are in trying to separate, to make the signal clearer, almost by getting rid of some of the static. So if we could find the people who have meet the most of those hypermobile EDS criteria, find what's common between them, it'll help us find the genetic cause. So in some regards, unnecessary diagnosing or diagnosing people with hypermobile EDS when they're hypermobile has added to the confusion of trying to find it, because there's so much static when you're trying to hear that song, that sound.
Right. Thinking about genetics, and, one person asked, is it logical that if one of the parents has EDS, that when the kids are hypermobile, it's EDS, or is it possible if they only have like HSD, I guess, hypermobile syndrome?
Yeah, that's a great question. That's a really great question. And again, without being able to address any specific people, I can just tell you I'm in this situation quite a lot. So I'm just going to kind of go back in my mind to a very similar situation. So a few things. When we start talking about hypermobile EDS, some of the criteria, so let's just pretend you have a kid who is extremely hypermobile, not even close to that cutoff. They're 9 out of 9 on a Beighton score. They're very hypermobile. But when you're looking at those secondary criteria, elastic skin, dental crowding, atrophic scarring, things like that. And let's just say they don't meet all of that criteria. And so therefore the geneticist doesn't want to give that diagnosis. Part of the tension also is recognizing that if all of a sudden 2 years later, that child develops hernias and then has a prolapse, which is an unusual thing for a kid, all of a sudden they get a genetic diagnosis when they didn't have it before. So it's one of those things that a lot of it, in my opinion, does require a little bit of humility of recognizing that what we're seeing is a spectrum of connective tissue laxity and we have to recognize that. And let's say a parent who meets the criteria for hypermobile EDS and their child does not, probably their child will at some point meet that criteria. The genetics don't change.
Right.
It's just time will start to make things clearer.
Right. And genetics, many insurances don't cover genetic testing, and that can be expensive. And so you really have to decide how much is that going to alter treatment or alter what your child should do or shouldn't do. And one of the, we see clinically, we see a lot of kids who are hypermobile, and they've been doing gymnastics when they were young because they could do splits, they can turn themselves into pretzels because they're hypermobile. Is that something for hypermobile kids? I mean, forgetting about a diagnosis of HEDS, that parents should allow hypermobile kids to do? Does that create problems down the road?
Yeah, that's an excellent question. So I'm a big proponent of physical activity. And I balance that with saying that not all activity is equal. So I should give full disclosure. So I have a connective tissue disorder, right? Dr. Zeltzer, we've met. We know I have short stature. And so the way that I think about this is the same way that I would think about any child with a connective tissue problem, okay? Which is to say movement is helpful. Movement is good. Strength is good. Muscle strength is really good. When I start to think about, like, if I knew a child, let's just say a 5-year-old had hypermobile EDS, however I knew that, let's just say I knew that, I would probably not recommend that doing gymnastics specifically, partly because it can stretch their ligaments, their joint capsules. It's almost encouraged in that way. And that can be part of the further injury, as it can throw off people's body position sense, which lives in those joint capsules and in those ligaments. That's where those nerve endings generally are. So all those micro traumas to the joint capsules and ligaments that can accumulate over time. Now, doesn't mean no physical activity. I personally recommend the ones that focus more on joint position sense. So for instance, ballet, you're not looking to stretch your body to the furthest that it maybe can go. You're looking to make your arms straight, but not overly straight. Or maybe more like contemporary dance or soccer or swimming, all things where we are strengthening our body and we're trying to get it into the correct position without just pushing how far our flexibility can go. And the hard thing is kids often gravitate towards these sports because they're naturally good at it, but not realizing that nature can catch up with you, several years later, typically around teenage years.
Right. It's interesting. There's a lot of discussion back and forth on the chat box about this idea of genetic testing. And then we'll get to treatment options and other things in a minute. But one person writes, we were told we should test genetic testing to rule out the scarier types of EDS. And then us too, especially when there's so many comorbidities. And then please explain why collecting DNA is not helpful. I'm an analytical chemist, and not collecting data is an ineffective way to diagnose EDS. So it's the
Sure.
issue of value of genetic testing.
Right. So, as a non-geneticist, I'll do my best. Okay. So I'll do my best to clarify. So the first thing is, it's not a matter of just collecting all data, it's collecting the right data. And I think that that's the important thing for that person who said they're an analytical chemist. You don't just, you have, when you're testing something specifically, it's best if you know exactly what you're looking for. We don't want to go on these fishing expeditions necessarily, where we just test everybody's genome for anything that's a problem, because a lot of times we'll see things that very well might not become problems, right? And that adds more confusion and more follow-up testing and can create a lot more consternation amongst families, a lot more impact to the healthcare system. So that's one thing. Now, when people start talking about it's worth testing to rule out the scary causes, I sometimes test. I'm not saying that I don't, I never test, right? Personally, I can tell you my personal experience, I'm more likely to test when I hear things that are not usual for the patients I take care of. I don't know if that's would be sort of in your practice, Dr. Zeltzer, but if you're hearing something like, whoa, this is, we got an MRI of the brain for someone having frequent headaches, and there might be an aneurysm there. Absolutely. Testing for something like a vascular EDS would be indicated there. And other people might disagree, and that's perfectly fine. I'm not necessarily saying that as a strong testing is never indicated.
Right.
The hard thing is, again, it's walking that line between something that might be as common out of 1 of 100 people, but we don't do genetic testing out of 1 out of 100 people. If it's that common, it should be in the newborn screen, right? And so that way it's picked up for everybody when they're born. It's just one of those things that I don't routinely order genetic testing when I'm trying to understand hypermobility. And part of that, as you are, I think, going to allude, moving on to the next section, is it doesn't necessarily change our management very often, unless you start getting into the rare forms of EDS.
Right. Let me bring up another issue just to change direction a little bit. Certainly clinically, and this is also parents' report in the chat box, there are a lot of other conditions that kids with hypermobile EDS may also have. POTS, for example, postural orthostatic tachycardia syndrome, meaning you go from, I mean, the easy way, heart rate from sitting to standing goes up 30 points, beats per minute. They may have a lot of GI issues. Can you talk about sort of clusters of other symptoms that are very frequently accompany kids without any genetic markers, but who have hypermobile EDS?
Sure, sure. So connective tissue is everywhere, right? Like it's what connects our body. It's a glue. So when you have excessive laxity or movement of it, it can affect all aspects of the body. And there's a lot that we don't know about these topics. What the data shows from trying to tie these things together, from my understanding of it, my read of this and doing this for a living, is that we have a combination of peripheral tissue and neural control. And a lot of times people will see doctors who will only see one, or they'll see the other, and not be able to see or work on both at the same time. So as an example, when we start talking about POTS, connective tissue makes up the blood vessels. And so a lot of people with hypermobility, hypermobile spectrum disorders, hypermobile EDS, will have stretchy blood vessels that'll promote pooling of blood in their legs. So when they stand up, it doesn't get squeezed back to the heart in a very rapid manner. And so that can lead to symptoms like POTS. But at the same time, POTS is also like that response of contracting blood vessels, and how the heart is controlled is under neural control, the nervous system. So part of POTS in patients with hypermobile EDS is this connective tissue flexibility, but the other part is this nervous system control over these functions that can go haywire and can get excessive. And that's a really complicated thing to decide, because we don't have great testing to tell us how much of this is from the stretchy vessel, how much of this from the nervous system. It's the same problem with irritable bowel syndrome, with IBS. So the colon is a stretchy organ. It's a hollow organ that the way it works is that its purpose is to hold on to poop. So that way we can poop at a time that's convenient for us. So we don't lose excessive water after the washing machine of our intestines has absorbed the small intestines have absorbed our nutrients. It's stored there for us to be able to defecate at a time when it's convenient and not get super dehydrated, reclaim that water. So when you have a tremendous amount of stool in there, when the colon is really stretchy, you don't get that same stimulus to squeeze it out. So a lot of folks with hypermobility struggle with chronic constipation. And a lot of times they'll see, pediatricians, gastroenterologists who might not be recognizing the connective tissue process and realizing that the normal treatment recommendations for constipation and, Johnny or Jane America, it's not going to necessarily work if you've got a connective tissue problem. You have to kind of take different strategies. But remember, the purpose of the colon is that when it gets stretched out enough, you get this nervous system signal to squeeze it out. It's a reflex. But with conditions like irritable bowel syndrome, the nervous system control can get amplified, can get hyperactive. So the gut can get extra sensitive and extra mobile, or a dysmotility, is what we call it, and lead to things like IBS. So from my perspective, a lot of these challenges are all intimately related. They're almost like the same fundamental problem, but affecting all the different organ systems where people have connective tissues. The hard thing is that the treatments are all different, and you see a bunch of different specialists. And so patients can be told a lot of different things. Some people from people who are very savvy and experienced treating EDS, and they can be told something completely different from somebody who's not savvy or experienced treating EDS. And that can create a lot of confusion, a lot of complexity.
Yeah, I that's really, really helpful. And it's interesting. We talk about kids with multiple problems in their body that are getting in the way of function. And um, and then sort of deciding where do we bring our child to get help. And a lot of times it's like the elephant and the blind man, depending upon whom you're going to, you bring to an orthopedist and they look at it from their view of training. And, and I sort of see it as carpenters. And, and then you bring to the gastroenterologist for the internal GI issues, and they're plumbers. I mean, they're looking at the whole system from the brain down to pooping or vomiting. And you look at you go to the cardiologist, and somebody might have a normal flow murmur tall, and people often have but that doesn't mean anything. But then you worry about, you go through a whole cardiac workup, or they have fatigue, go through a cardiac workup, and they'll say, oh, it's dysautonomia. Some neurologist will call it a small fiber neuropathy. So the idea, or immunology, MCAS, so they're, it's like the blind man and the elephant, the same condition, if it impacts multiple systems, gets named different things depending upon whom you're going to. And pretty soon you're bringing your child to 5 different specialists. And the issue is, and this is sort of the biggie, okay, so you have names for these different things. Your child has gone through gazillion tests. So, but they're still suffering. So what do you do? So somebody comes to you, they've already been to 14 different doctors, and usually that's the minimum of kids who come see us. Kids have 3 years of 44 different doctors, specialists all over the country. So how do you help these kids?
Yeah. So, I mean, you basically just summed up what is my job and how do I do it, right? Like it's how much time you got. So, so, I like to take a step back. Okay. So for the first thing, you're right. Like names matter, right? You see a GI doctor and they have a name for a condition that they're treating. You see a cardiologist, they're going to have a different name. Part of the problem is that we don't have the right names for these problems. Do you know what I mean? Like for instance, you use the our favorite analogy of a bunch of blind men trying to evaluate an elephant and evaluating different parts of the elephant and thinking that they're different animals because they're not able to see the big picture. The person seeing the tail thinks it's a snake, or the person seeing the big ears thinks it's, I don't know, like a plant or something like that. But wouldn't it be nice if we had a phrase that they're all parts of the elephant? You know what I mean? And so, I think that's some of the intent with people using terms like getting away from POTS and moving towards dysautonomia, to say it's this abnormal autonomic response that's widespread. It's just not limited to the heart rate. So there are efforts to try to give a single word that is a little bit more unifying. But at the end of the day, modern medicine doesn't have the right objective test to give. It's not the same as cancer, where somebody can just cut a tumor and stick it underneath a slide and say, there's your diagnosis. A lot of these things, we just don't have the right test yet. And that's really, really unfortunate. So what I do is the first step is go through and look for the common themes, the common threads. Because at the end of the day, the whole point of a diagnosis, from my mind, is to tell you a few things. What is somebody at increased risk for? Okay, so what do you need to watch out for? Okay, does this symptom that someone's complaining of mean that we need this testing in this person with this genetic disorder, but not in the others? If that makes sense, right? Somebody, going back to our example earlier with a vascular EDS, who's now having double vision, or they're having an eye moving off to the side. Pretty much everyone's going to get an MRI in that patient, but somebody with vascular EDS is going to get an MRI with a vascular study as well, right? So that diagnosis has value in that way. The second thing is a genetic diagnosis, or a diagnosis really, if you think about it, where these diagnoses came is doctors over 100 years, sometimes even longer, took a bunch of people complaining of similar conditions who've never met each other, not necessarily related, and basically started to group them together to say, you all have, we think, the same underlying condition, and this is what happened to those 5 people before you. So these are the things we need to watch out for in these other people. So we start to get, we're kind of predicting the future a little bit. It's not something that we know for sure, but it gives us some guidance to say, these are the things we got to watch out for. So when I evaluate kids who have these widespread issues, I try to get to the root problem, and I'll look at something and say, is there hypermobile EDS? Okay, what are patients at risk for? Okay, has that evaluation been done? You know, we can't just do a whole body MRI every 6 months to check on things, but we couple that together with our physical exam with symptoms and make sure that that stuff has been looked at. The second thing is we look to see the trajectory that someone's going on, and we say, how can we move that needle? We see maybe someone moving towards a course of having more and more widespread pain and loss of effective autonomic control. How can we regain that? How can we reclaim that? So, you know, in many of those situations, we almost have to turn it on the upside down. You know, the natural course with a lot of hypermobility syndromes is it starts off as being more focused and localized. Someone might have knee pain. Someone might have wrist pain. And as that course increases in time and in stress and strain on the body, it starts to ping the nervous system to where the nervous system starts becoming overly reactive, both in its sensation and also in its movement. So both in the autonomics and also in the muscle activation and things. And then finally, that takes a toll on people. Like, that stinks for that to happen. That's awful. So in some regards, what we try to do is I start at the end and work backwards. We start off by addressing how it's taking a toll on people, help them regain some control over their life. We don't start necessarily on the joint capsule if it is hurting everywhere. We start on the sense of gaining control in life. It doesn't mean the joint capsule is not a problem, but we have to start somewhere. And then we'll also work on that sensory and that nervous system component. And then we'll work on the joint strengthening. And a lot of times we have to do them all at the same time, which is when things get really, really challenging.
You know, I tend to think, and I'm gonna, because it relates to some of the newer questions, when kids have one problem, it's not uncommon for some kids, their developmental neurobiology, other stressors in life, if they super bright kids that might have the ADHD or specific learning disability, dyslexia, but accumulation of stressors affects the balance of the body.
Mm,
And pretty soon you get hit enough times, the body starts falling apart or becomes dysregulated.
mm-hmm.
To me, when kids develop POTS and they have their autonomic, their internal signaling system starts falling apart, then they get more GI problems, they get other, chest pain, other kinds of, their pooping gets out of balance. So you can see how one problem leads to another. They're super bright kids. They start missing school. Then there's anxiety about all the school missed. Kids who are perfectionistic, used to getting straight A's. We wrote a book, The Smart Brain Pain Syndrome, but there's something about kids who also, you develop a memory of an experience, and that can add to it. So it's one thing after another, after another. And for some of these kids, we now have what we call functional neurologic disease. So kids that become blind, kids that have seizures where there's no normal electroencephalogram, and these other symptoms, but these are all symptoms of a body becoming more and more dysregulated.
Right.
And so, and if you go to multiple specialists, they're going to go work on their expertise, their body part. And so and I think one of the questions was, so who do you go to take care of this from a developmental and systems perspective? Because all these things are related as opposed to specialists for each part of the body.
Yeah. And that's an excellent question. And I mean, my bias, I'm sure your bias, Dr. Zeltzer, is that's the role of a good pediatric pain physician, right? Is to kind of be that, that big picture. I think that there's so few of us, right? I mean, there's, I don't know, maybe less than 100 of us across the country. And as pediatricians, I mean, there's what, 4 of us, So, so it's just very, 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 there's not enough of us is the short story. I think the most important person to start with is someone who believes you, who is bright, who gets it, who understands the mind-body connection. So, Dr. Zeltzer, so what you referenced about the bright, precocious kid. So this has actually been studied. It hasn't been studied well, but kids with, amplified musculoskeletal pain syndrome have on average about a 1 standard deviation higher IQ. Like the kid being the brightest kid in the class is almost, it's all of the patients, right? And it's this almost tragedy of their nervous system is so good at learning that, all the capitals of all the states and being able to learn calculus when they're in middle school, that their brain can learn all these bad lessons, right? It can learn that when you're injured, you need to fix it, you need to fix it right now, but they can learn that lesson so well. Now, obviously, this is not voluntary, but meaning at a true neurologic level, it can learn it so well that they become hyper avoidant because they've learned that lesson too well. And then when anybody burns their finger, our body's natural reaction is to withdraw. You touch something painful, you step on a nail, the body's natural reaction is to do something about it, move, get yourself to safety. Their brains, their nervous system can be so effective at learning these things that it can lead to muscle spasms, excessive muscle spasms, which then neurologists might diagnose as a functional movement disorder or dystonias, where basically you have the one muscle trying to pull your arm back, another muscle trying to pull your arm out, and you end up with this lock and you just have muscles going in all directions, and that's painful.
Yeah.
So there seems to be something about these conditions that are tied into, I don't know, this brilliance that from a neurologic level of making these connections. Now, you also mentioned ADHD. We see a lot of ADHD in this population, and we don't know why. I don't know why. I mean, I think there's some who think about it in terms of the blood flow to the brain from the stretchy blood vessels in the brain, or maybe the autonomic control of the brain. But we also hear this stuff happen from a young age. We'll hear kids be very sensory sensitive. Even colic has been associated with higher rates of these conditions that we're talking about,
Right.
right? Colicky babies, growing pains from young ages. We hear all this stuff. And sometimes it might be a sign that it's a really sensitive nervous system. And we don't fully understand the reasons for that. I know we're seeing it more frequently than we used to. Just like we're seeing autism spectrum disorder more frequently than we're used to. We don't fully understand the reasons for that as well. So at the end of the day, if you knew that you were in this situation of a very sensitive child, there's actually a wonderful book series on the highly sensitive child. That for, as a plug, I can't remember the name of the author, but if you know that you're dealing with that, you start making steps to try to both nurture that sensitivity and celebrate it, but also trying to make it more adaptive to the world around. And so, when we're in these situations of kids who are, in a really tough spot, they've spiraled and they're kind of towards the bottom. We do that same thing. We have to help them become more adaptive to the world around them by desensitizing their body, but also celebrating the fact that they have a lot of character strengths that might have contributed them to getting into the spiral, but that doesn't mean there's anything wrong with them. It just means that they've got their brightness, their precociousness might have might have contributed at some point.
Right. Your discussion and a lot of the questions that I'm seeing, gazillion questions, but it reminds me of Tom Boyce, who's a developmental pediatrician, who wrote a book, and it was for the public based on his years of research, called The Dandelion and the Orchid. And the idea, and think about, for those who are on your kid, about 80% of kids are dandelions. You put them anywhere and they grow, they develop through all kinds of adversity. They're just hardy. And about 20% of kids are orchids. And as kids, we might call them neurodiverse. So their brain grows and develops in uneven patterns. So some of these kids might have characteristics of autism spectrum disorder. They may be hyperactive. They may have some learning disabilities. They're just more sensitive kids, sensory sensitivity, and they get overwhelmed by too much sensory overload. They don't have those filters. But so it makes it difficult when their brains are still developing. As they get older and their brains develop with the right understanding in childhood, and if their basic brain is smart, which most of these kids are, they become these super successful adults because of this brain, because of their neurodiversity. They become the Albert Einstein. Albert Einstein had dyslexia as a kid. He couldn't read. He's probably neurodiverse. But he could focus on math. He was a math genius, and he could stay with something, that sticky neural loop. So, so think of it. And a lot of the kids we see, their bodies easily get dysregulated. They may have a hard time at school, not because, they're getting straight A's, even if they're home and missing school, but it's too much stimulus overload and they get caught up. And that's I call it the Humpty Dumpty syndrome. You fell off a wall and now you've got POTS and you've got dysautonomia and you've got abdominal pain, you've got headache, and you can't function.
Right.
Well, how do we rebalance a system that's gotten out of balance? And
Yeah.
it's through it's not through just working on the right arm,
Right.
or just the headaches. What about it's how do you rebalance a system that's gotten off balance? And
Right.
kids, when they're really off balance, they're like volcanoes that periodically erupt to let off energy. And that's, functional neurologic disorders. They may go blind. They're not making it up. They're not doing it on purpose, but their body is showing evidence of stress overload and
Right.
it accumulates. So how do those are the kids we see, you see.
Yeah, I mean, and at the end of the day, you're talking about that term homeostasis, the ability that, like, if somebody kind of pushed you, do you fall over or can you kind of catch your balance? So life is always pushing us. So, and the thing is like, what we're talking about right now, we're actually kind of deviated a little bit, Dr. Zeltzer, from hypermobile EDS, because a lot of what we're talking about applies to hypermobile EDS, but it's not unique to hypermobile EDS, right? I mean, it could be related to a lot of other things. But hypermobile EDS, these kids are particularly vulnerable to this as well. So I like to start from the basics. I think eating, drinking, breathing, sleeping. Actually, not even sleeping, eating, drinking, breathing. Because those are the three things that if we stop doing, we as humans, as organisms, we die. Okay. So you have to eat, you have to drink, you have to breathe. Pain in this like little made up architecture, kind of mimicking Maslow's hierarchy of needs, is more in the category of about protection, because that's where the body is trying to protect itself. It's actually a higher level process than eating, drinking, breathing. So the first thing I start with is we need to eat, we need to drink. If it's hard to eat, if it's hard to drink, we have to start there. And when you get into, like when you said, your Humpty Dumpty syndrome, Dr. Zeltzer, it's really hard where the treatment for that broken eggshell is over there and that one is over there, and they're in polar opposites, and you're not sure which way to lean. Someone's being told to eat more to help their headaches, but eating causes stomach pains, as an example, right? Like, what do you do when you're stuck in that loop? And we're treating one problem worsens another problem, or it gives you symptoms of another. And at the end of the day, especially when you start having kids who struggle already with their own self-management, kids with neurodiversity, ADHD, it's like having a really disheveled room and they say, I don't know where to start. And you just have to start somewhere with one thing. And so I generally ask the patients to help me prioritize what they want. My priority is eating, drinking, and breathing, good diaphragmatic breathing, eating nutritious food, hydrating our bodies. Not that that's going to fix things, but that's a place to start. But then I let them give me a priority of theirs, which is to say, how can I help you live? Where can we start so it's not all just adding more homework and chores to your life? Like, are you wanting to get back to something fun that we can start working towards at the same time?
Right. And I see, and I just want to comment, somebody mentioned the idea of, these kids are not more sensitive, they're dysregulated. And when I say sensitivity, of course, not all kids with EDS have hypersensitivity, but there are kids developmentally whose nervous systems have a harder time filtering out stimuli. So too many stimuli coming in can become a stressor and help dysregulate a kid's nervous system. It's not kind of, we think, emotional sensitivity. We're talking neurobiology, developmental neurobiology. So it's not meant in any, it's a descriptive term, not meant with any, oh, they're too sensitive, they should just toughen up. That's not what's meant. So I just want to clarify.
Right.
And a lot of this, doctors will say, well, your kid's just stressed, go see a therapist or go see a psychiatrist. Well, of course your kid's stressed if they're unable to go to school. They have all these symptoms and it's sort of chicken egg, but that's why you need a mind body, and I always say brain down, body up environment, and understanding the kid and giving the kid a role, as you say, in their priorities. And
Right.
so you give them a sense of self.
And I would say, I mean, I take care of a lot of kids with hypermobile EDS. I take care of a lot of kids without hypermobile EDS. And I don't think the kids with hypermobile EDS are more stressed than any other kid. I mean, I think we need to start from the premise that most teenagers these days are stressed, but so are most adults.
Right.
Right. So that's, I'm not saying that with judgment towards kids. It's just, it's a tough world, tougher than when I was a kid. I think what's important to say, though, is that it seems that the stress hits kids with hypermobile EDS differently. So, for instance, if you have looser joints, and if somebody did not have loose joints and they carry their muscle tension in their neck, they might just say, my neck feels tight. But if you have hypermobile joints and your muscles in your neck tighten up substantially, that might be more likely to throw off the alignment of your neck, and that might be more likely to trigger migraines. Right. So to me, a lot of doctors, I think inappropriately, will say, oh, you're just stressed. And what they kind of say is stress, black box, symptom. Right. Whereas recognizing that it's things like stress, and again, it could be any number of things. It could have been a car accident. It could have been, so it's not, I'm really not trying to promote a psychological component to it. It's any deviation from normal. Kids can be more likely to develop that muscle tension to try to stabilize the loose joints. Heart rate might spike up higher to try to keep up with the elastic tissue of the blood vessels, right? But how does the heart rate speed up? Well, it does so under the control of stress hormones. And so that can make that symptom alone, just like if somebody pounded a Monster energy drink, can make somebody feel on edge, right? So it's really fast that these things become sick or circular, right? Somebody has a normal psychological stress, like me doing this talk as an example, right? Like, not trying to pathologize things for anybody, but then it can quickly have an over impact on the body for people with connective tissue disorders.
Sure.
And so, and I think that that's really important for people to say, or for people to hear, is to say that these are problems that can easily spiral onto each other.
Right.
And the unfortunate truth of it is that we don't have like a blood test to tell a doctor who's not aware of these things that it is not, like somebody could have hyperthyroidism and feel the same way, but there's a blood test to say it's hyperthyroid. Aha. Now the doctor believes why you feel this way. We don't have that for these conditions, even though the biology is just as real.
Right. I also, well, let me just ask one question that was brought up. My brother, me, my mother all have EDS. That's uncommon. Does that make it any more likely that my kids will also have EDS?
Yeah, so like hypermobile EDS is an autosomal dominant condition, which means that when it is passed on, it is passed on with one of the two genes from you passed on to the other. So it's not 100%, But it is it's a significant likelihood.
Mhm. Yeah, and we see a lot of families where genetics have been negative because there's no gene yet identified or cluster, but you see it in families, and the question, yeah, the epigenetics, the question really is, where do you go for your kids' help? How do you get help? How does, especially when other symptoms start layering on, it's
Right.
not just, having kids have very flexible, and there used to be the Baton criteria. I know EDS has new criteria, society, and that's again a descriptor. And having done research, when you're doing research, you need very clear definitions. So everybody who's in that homogeneous group can respond or not respond, because we all have so many different things. Even if we have HEDS, we may have that and POTS. Somebody else may have that, no POTS, IBS, it's
Right.
a different group. And you want to look at how much of the system is dysregulated over what period of time, in whom, what's the birth history, the developmental history, and then how do you enhance function and sense of well-being for the individual? And
Right.
really and pain is often the last to go, but there's pain that's harmful and pain that's hurtful. And how do you cope until the pain can become from foreground to more background? And it's
Right.
not a quick fix. And medication can help, but it's not the answer, the sole answer. And it's really getting a body that's out of balance back in balance, putting Humpty Dumpty together again, and it's doable. I want to thank Dr. Windsor for his time. Let us know if you want more of this or what other topics. Just email admin@mychip.org and let us know what topics you want us to do more of these webinars on. There are a lot of people. Thank you all for excellent questions. And you're a smart group, and we really appreciate all of your participation. And if you you don't have to, everything we do is for free, but if you want to donate to support, doing more of these, go to mychip.org//donate. I never get that right. Anyway, thank you all.